My area of research in multiple sclerosis is cognition and depression. So with depression, I look at brain imaging changes that you might find in people with MS who become depressed. So we've done a number of detailed MRI studies. The rates of major depression are high in people with MS. 1 in 2 individuals over the course of their lifetime will develop a major depressive disorder. So one of the questions is, why is depression so common in this disease? And for many years it was thought, well, if you've got an incurable disease like MS and you're a young person, then of course you become depressed as a reaction to the disease. And I think that's certainly valid. There's no doubt that's an important reason. But now with sophisticated brain imaging, we're able to tease out some of the brain changes that characterize depression in people with MS. It might be part of the disease, yes. I mean, certainly some people will get depressed as a reaction to the disease. You can't minimize that. But there are some individuals who do not seem to be particularly fazed by having the disease, whose life is actually still quite good, who don't have significant physical disability, who don't have financial problems, and their relationships are good, and their marriage is good, and they can still develop a clinically significant depression. And so why? And in those patients, if you go looking very carefully at the brain changes, what the MRI data show is that if you've got a significant lesion burden in certain regions of the brain, anterior temporal, medial frontal, if you've got some atrophy in those regions as well, then your chances of developing depression go up substantially. We've also done some brain imaging work looking at diffusion tensor imaging and focusing down on those parts of the brain that they appear normal on MRI to the naked eye, but we can extract information from the MRI that suggests there's pathology at work over here. And once again, if you've got DTI changes in medial frontal and anterior temporal parts of the brain, that too adds to a potential cause for depression. So when you put all the MRI variables together, the bright lesions, the hyperintense lesions, the black holes or the hypointense lesions, the sites of atrophy or brain shrinkage, and the DTI abnormalities, all those brain metrics can account for about 44-45% of the variance as to why someone becomes depressed. So very clearly, in some individuals, the depression is a direct consequence of brain pathology. I think the final pathway is the same. I think depression is depression. I think some people will have their biochemistry triggered by anatomical changes, some people by life stress, many people by a combination of the two. But ultimately, the final pathway is going to be the same. And then you've got a couple of treatment options. You can decide to use antidepressant medication, which some people want and other people do not. And we now know that there are effective psychotherapies for depression as well, in particular cognitive behavior therapy. And some people would prefer to go the talk therapy route as opposed to medication. Some people will take both, medication plus cognitive behavior therapy. No one really looked at that from a research perspective, but what we do know is this, that the high rates of depression in MS cannot be attributed to people having depression before the onset of the MS. So there's something clearly linked to the disease that's pushing up the rate of depression. And intriguingly, the rate of depression is higher in MS than most other neurological disorders as well. So there's something particular about the disease, demyelination, uncertainty, inflammation, neurodegeneration, that leaves people vulnerable to mood disorders. Well, I think they should. MS is not an unusual, uncommon disease. In Canada, Canada has the highest incidence of MS in the world now. So there's going to be, estimated 100,000 Canadians, for example, with MS. Obviously, many more people in the United States. So, general psychiatry should know that MS is a disease that comes with a high rate of depression, and they should be open to treating people with multiple sclerosis. If you're going to leave the treatment of depression to those very few psychiatrists who work within the MS field, you don't have enough treating physicians. So the way neuropsychology has conventionally worked is that someone comes along to the office for cognitive testing. They step inside a very quiet office, the door is closed, a sign is put up outside, do not disturb, testing in process, and you create a kind of environment that's ideal, that the person can concentrate in, but that's not the real world environment. So we're trying to build an environment using computers that simulates an office, for example, while at the same time testing a person's cognition. So we're bringing in distractors. We're using distractors as part of conventional neuropsychological testing, because we know that this is going to mimic what people confront in an office, for example. And with computers, you can do it in a standardized way. So we're taking tried and tested cognitive paradigms. We know they work. We know they're sensitive to people with MS. For example, the symbol digit modality test, a very good test for teasing out cognitive difficulties in people with MS. And embedded within the symbol digit, we now put distractors, a telephone ringing or a car horn sounding. And because it's computerized, everything is driven by computer, it's completely standardized. So everyone's going to get the same kind of distraction.